Did you know that children snore? I mean, really snore. And it's often, well, far more significant than most of us probably realize. Today, we're embarking on a really in-depth exploration, a deep dive, into something called pediatric obstructive sleep apnea, OSA for short. And while, that snoring might seem kind of harmless, maybe even cute sometimes, it can actually be a signpost for a serious underlying condition. We're going to uncover how breathing patterns during those really formative years aren't just about getting a good night's sleep, they actually profoundly shape facial growth and long-term health.
Exactly. And our mission here in this exploration is to really unearth that crucial connection. It's often quite surprising, this link between pediatric OSA and oral facial development. We'll get into the diagnostic advancements that are really changing the game, and also a pretty surprising array of treatment approaches. We're looking at both, immediate relief, but maybe even more importantly, long-term prevention.
And to do that, we've really dug into a stack of fascinating sources. We're talking cutting-edge medical research, in-depth orthodontic studies, clinical reports, all tying it together. So this isn't just theory, right? This is evidence-based stuff.
Okay.
Then let's start to unpack this. So let's kick things off. When we talk about pediatric OSA, what are the absolute fundamentals our listeners need to get their heads around? And how do we even start to measure how much it's affecting a child?
Okay, so fundamentally, pediatric OSA is when a child's upper airway repeatedly gets blocked. It can be partially blocked, sometimes completely blocked, all while they're asleep. Just imagine moments where the breathing isn't just difficult, it actually pauses. The main way we measure how often this happens and how severe it is, well, it's called the apnea-hypopnea index, the AHI.
Right.
Right, so an apnea is a complete pause in breathing, even just for a few seconds. But it causes a noticeable dip in their blood oxygen levels. On the other hand, that's where their airflow significantly drops, say by about half. And it lasts for at least 10 seconds, also causing that oxygen dip.
Okay, the AHI number, that sounds key. But here's something really crucial I picked up from the research. Not all these events are created equal, are they? Can you help us understand why a child who has mostly apneas, those complete breathing stops, why they're considered more severe, even if their total AHI number is the same as another child who has more hypopneas, the partial blockages? What's the physiological difference there? Why is it more concerning?
That is a really subtle but critical point, yes. A child having mostly those complete breathing stops, the true apneas, well, they're actually facing a more severe situation than one with the same number of partial obstructions, the hypopneas. Why? Because those complete stops, they lead to more profound, more dangerous drops in oxygen saturation. Their body is essentially starved of oxygen for longer or more deeply during each event, even if the overall count per hour, the AHI, is the same. To put that into context, right, an AHI of 60, that means a child's breathing is stopping or significantly desaturating every single minute they're asleep. Their body is basically in this continuous fight just to get enough air, even when they're supposed to be resting and recovering. Think about how exhausted you would feel if that happened to you. 60 times an hour.
Wow. Yeah, putting it like that really brings it home. And this problem, it's actually more common than a lot of people might think, isn't it? Snoring, I saw numbers up to 7.5% of kids between 2 and 18. And mouth breathing, that range was huge, like 3% up to maybe 50% in young kids.
That's right. The range for mouth breathing is wide, depending on the study and age group. And for pediatric OSA itself, the prevalence is generally reported between, say, 0.7% and 4% in that same age range. Still significant.
Absolutely. And it's not just about sleep, is it? There are these significant comorbidities, other conditions that go along with it.
Definitely. Beyond the obvious sleep disruption, pediatric OSA is often linked to behavioral problems. Think ADHD-like symptoms. Also developmental delays, chronic fatigue, anxiety, depression, even things like teeth grinding during sleep, that's sleep bruxism, and periodic limb movement disorder where their legs might twitch or jerk. What's often missed, and this is really important, is that these other symptoms frequently lead to OSA being underdiagnosed, especially when parents bring a child in mainly because of behavioral issues. The sleep problem, the root cause, might get masked.
Okay, so beyond the immediate symptoms and this big challenge of underdiagnosis, you hinted earlier at something truly surprising, this idea that breathing isn't just about sleep, but it actually, sculpts a child's face. How does that work, and why is this link so critical?
It's absolutely critical because the way a child breathes, particularly during those key growth years, it profoundly impacts their craniofacial development, how their face and jaw grow. So when children experience abnormal nasal resistance, maybe their nose is stuffy a lot, often because of enlarged adenoids and tonsils, right, common culprits, they're basically forced into breathing through their mouth. habitual mouth breathing. And this chronic mouth breathing, over time, leads to significant noticeable changes in their facial structure.
Whoa. So just to be clear, you're saying constant mouth breathing actually reshapes the bones, the facial bones, the jaw over time. Can you sort of paint a clear picture for us? What do these long face syndrome changes actually look like?
Exactly. It's a reshaping process. We see specific craniofacial and dental alterations. Facially, they can develop what's often called long face syndrome. It's characterized by a noticeably lengthened lower part of the face, also flattened cheekbones, and a kind of downward rotation of the jaw and the whole mid-face structure. And this physical change, this downward growth, actually reduces the critical space in the back of the throat. It narrows the oropharynx, the airway itself, from the inside. Then if you look inside the mouth, we often see a high, narrow palate, the roof of the mouth, which really squeezes the space available for the tongue and again for the airway right behind it. And dentally, well, these kids often develop narrower upper dental arches and increased overjet. That's where the top front teeth stick out quite a bit further than the bottom ones. And often a reduced overbite, meaning less vertical overlap of the front teeth. They might also have shorter lower jaws, develop an open bite, where the front teeth don't even meet when they close down. And they're generally more prone to teeth crowding or misalignments like a class 2 bite, or where the back teeth don't fit together evenly. It makes their bite sort of uneven.
Wow, it really is all connected. Which brings us to this intriguing idea I read about, the craniofacial dystrophy hypothesis, CFD. This theory suggests it's like a domino effect, right? When teeth are misaligned, what dentists call malocclusion, it's not just about looks. It can be linked to other health problems, possibly because maybe the child isn't chewing as vigorously, or their tongue and jaw aren't resting in the right place. Think the mouth always slightly open, muscles may be weaker or not working properly. It really highlights this deep feedback loop between how we use our mouth and how our face actually develops.
Yes, and this connection really highlights a crucial window for facial growth. Get this, 60% of a child's facial growth is done by age 6, and about 90% is complete by age 11 or 12. This just underscores why early intervention is so incredibly important. Catching things early matters. And what's fascinating here, recent MRI studies have actually confirmed something else. They've confirmed the heritability that it can be passed down in families of key craniofacial structures linked to OSA risk. Things like the width of the jawbones, the mandible and maxilla, and the size of that throat space, the oropharynx. So it suggests that genetic predisposition can definitely play a role, setting the stage, so to speak.
Okay, so knowing all this, how do we actually diagnose pediatric OSA? You hear about sleep studies, polysomnography or PSG, right? That's still the gold standard.
It is, yes. Polysomnography, PSG, remains the gold standard for diagnosis. It's a very comprehensive overnight sleep study. It records brain activity using EEG, eye movements with EOG, muscle activity EMG, plus heart rate, airflow through the nose and mouth, breathing effort, and crucially, blood oxygen saturation. It gives a very detailed picture.
But I imagine getting one isn't always easy.
Exactly. Despite being the gold standard, PSG definitely has limitations. The main ones are limited availability and access. There just aren't enough labs or appointments. And this can lead to really significant delays in getting a diagnosis, sometimes months or even longer. This is where portable monitors, PMs, come in as a really valuable alternative. Level 3 PM, something like the Metabite device, for example, they're actually quite reliable for measuring that AHI score. They show a strong correlation with the PSG results, especially for identifying severe cases. Think of them as a good snapshot, particularly when the problem is significant. They're highly sensitive, over 93% sensitive for severe OSA, which is usually defined as an AHI of 10 or more events per hour in kids. However, they are less accurate for the mild and moderate cases. And the oxygen saturation data can sometimes be less reliable in younger children, say between 7 and 11 years old. It's also worth noting having a trained sleep technologist present during these portable recordings. Even if it's at home, just having them set it up properly and maybe monitor it briefly, that significantly improves the data quality.
Ensures things are recording accurately. Then you have level 2 PMs. These are a step up. They do include the EEG for brain activity, EOG for eye movements, and EMG for muscle activity. This allows them to identify cortical arousals, brief awakenings caused by the breathing events, and also differentiate between REM and non-REM sleep stages. That gives a more complete picture of the obstructive events and their impact on sleep quality. They also tend to have better signal stability when used unattended at home.
Okay, so we have the gold standard PSG and these portable monitors offering more access. Given all this complex tech, what role do simpler tools play, like questionnaires? What does this mean for you, the listener, maybe wondering about your own child?
Yeah, simple questionnaires definitely have a role. mostly in initial screening. For instance, the Pediatric Sleep Questionnaire, the PSQ. That's actually the only one that's been formally validated for screening for sleep disorder breathing in kids. But it's really important to remember it's a screening tool, not a definitive diagnostic one. Think of it like a red flag system. It helps identify kids who likely need further, more detailed investigation, like a PM or PSG.
Got it. Screening, not diagnosing. Beyond questionnaires, what about just looking at a child? Or using imaging? What other visual clues or techniques do specialists use to understand what's going on with the airway and facial structure?
Oh, visual assessment and imaging are crucial pieces of the puzzle, too. Just clinical observation, right? Looking for specific signs. Things like those long adenoid faces we talked about. Or maybe a child with a mid-face hypoplasia, where the middle part of their face looks a bit underdeveloped or set back. Or a very small or receding lower jaw, micrognathia or retrognathia. These are strong indicators. Or even more obviously, actually observing the child having pauses in breathing, apnea, or seeing that bluish tint around the lips, cyanosis. Those are highly telling. Then for imaging, while standard 2D X-rays of the head and face, cephalometric radiographs, can be used for initial screening. 3D techniques like cone beam CT, CBCT offer incredibly accurate anatomical pictures, much more detail. They can clearly show a diminished airway space, and they can even reveal the positive impact of treatments like rapid maxillary expansion, showing how much space was gained behind the palate. MRI, magnetic resonance imaging, is another powerful tool. It gives fantastic detail of the soft tissues, the tongue, tonsils, adenoids, airway walls. And it's also used in research to confirm those heritable craniofacial traits linked to OSA risk we mentioned earlier. Practically speaking, we're even seeing the use of low-cost photographic and video protocols now, used in orthodontic screening, for example, capturing specific facial features and profiles to help flag kids who might need a closer look for OSA. It's all about building that complete picture using multiple tools.
Okay, so once a diagnosis is made, thankfully there are treatments. Several different approaches, really, all aiming to improve the child's daytime alertness, their behavior, their overall quality of life. Where do doctors typically start?
Right. So the most common intervention, and often considered the first-line treatment, particularly for children who have OSA and clearly enlarged adenoids and tonsils, is an adenoid tonsillectomy, or TNA. That's the surgical removal of the tonsils and adenoids, and it's generally highly effective. It improves symptoms, reduces those obstructive events dramatically for many kids. However, some children might still have some residual obstruction afterwards, or they might have less satisfactory results, especially if they're significantly overweight or obese. Obesity complicates things. It's also really crucial that high-risk patients, like kids under 3 years old, those with very severe OSA to begin with, or those with underlying heart issues, significant obesity, or certain craniofacial syndromes, they really need inpatient monitoring right after the surgery, just to be safe during recovery. And a huge benefit of TNA, circling back to our main theme today, is its potential ability to help restore normal facial development patterns. By removing the obstruction, ending the chronic mouth breathing, it lets the face grow more normally again.
That's fascinating. Removing the blockage lets the face get back on track. Okay, beyond surgery, you mentioned orthodontic interventions. These seem to have a really direct, almost mechanical impact on the facial structure and airway. Tell us about rapid maxillary expansion or RME. How does that work?
Yeah, RME is a really neat orthodontic approach. Think of it like gently widening the frame of a house to make more room inside. A small appliance is fitted in the roof of the child's mouth. It's custom made. And then, usually the parents turn a tiny screw on the appliance just a little bit each day, typically for about 3 to 4 weeks. This applies a gentle orthopedic force that gradually widens the suture in the middle of the upper jaw, the maxilla. It physically creates more space side to side in the upper jaw and the nasal cavity above it. After the expansion phase, the child usually wears a retainer for about 4 to 6 months. This allows new bone to fill in that gap, making the expansion stable and permanent, holding that wider airway open. This procedure visibly creates space. You often see a temporary gap appear between the front teeth, which closes later. And interestingly, it can also have some subtle positive effects on lower jaw growth and positioning. Studies clearly show RME has a significant positive impact on pediatric OSA. It often helps resolve those residual symptoms that might linger after a TNA. And in some cases, particularly milder ones, or those primarily caused by a narrow maxilla, RME alone can actually completely resolve the OSA. A really significant finding is its proven ability to increase that crucial cross-sectional area right behind the hard palate, directly improving the airway dimensions.
And for more complex cases.
Right, for more severe situations, or maybe when expansion is needed both sideways and forwards. There's a surgical procedure called maxillomandibular advancement, or MMA. This involves surgically moving both the upper and lower jaws forward. However, due to ongoing facial growth, MMA is typically not performed on non-syndromic children before about age 14, and it absolutely requires truly interdisciplinary care surgeons, orthodontists, sleep physicians, all working together. It's a major intervention.
Makes sense. Connecting the structure directly to the breathing space. Now, let's talk about something you mentioned earlier that sounds critical but maybe often overlooked, myofunctional therapy, OMT. What exactly is that, and why is it so important for these kids?
OMT, myofunctional therapy. Yes, it's incredibly important, and you're right, often overlooked. Essentially, it's a program of exercises. Exercises focusing specifically on the muscles of the mouth, tongue, and face, the oral facial muscles. It's critical because, well, there's compelling evidence suggesting that the absence of myofunctional treatment is directly linked to the recurrence of sleep-disordered breathing later on. The main goals of OMT are to restore continuous nasal breathing day and night, and to normalize tongue posture, getting the tongue resting up against the palate where it belongs, and also improving overall muscle tone in the lips, tongue, and throat. These factors are absolutely essential for proper airway development and function. There's even evidence it has potential to help correct high, narrow palates in premature infants. And fascinatingly, experimental studies on monkeys have shown how forcing abnormal nasal breathing can negatively impact facial skeleton growth. It reinforces the breathing growth link. A myofunctional evaluation typically looks for signs like, does the child have a low tongue posture at rest? Do they have difficulty with specific tongue movements, like making a clicking sound or touching their nose with their tongue tip? Or maybe problems keeping their lips sealed, like difficulty holding a button between their lips. There are specialists trained specifically in this field, orofacial myologists, and methods like the Buteyko breathing method, which includes exercises focused on improving nasal breathing efficiency and tolerance to CO2, fall under this umbrella too. It's really about retraining muscles and ingrained habits that profoundly affect the airway's shape and function.
It's so interesting. It's not just bones and surgery, but muscles and habits too. Beyond these major interventions, TNA, RME, OMT, what other treatments are in the toolkit for pediatric OSA, and what are some practical things listeners should know about them?
That's a vital question because it's often a combination approach. So continuous positive airway pressure, CPAP for instance, it is highly effective at keeping the airway open with pressurized air. Mechanically, it works. But the reality, especially with children, is that consistent use, compliance, can be a real hurdle for families. Adherence often struggles long-term. Studies show it can be as low as 30 to 40% sometimes. Getting a child to wear a mask all night, every night is tough. And while weight loss if a child is overweight or obese can certainly help improve OSA, it's typically a slower process and often unreliable on its own. So it usually needs to be part of a broader treatment plan, not the only strategy. Then for milder cases of OSA, or perhaps demanded some mild residual symptoms after surgery, even something relatively simple like intranasal corticosteroid sprays, prescription nose sprays, can sometimes offer relief by reducing nasal inflammation and improving airflow.
Right. It sounds like there are many tools, but TNA, RME, and especially that OMT seem really foundational for addressing the underlying structure and function. Now, thinking long term, it's vital for listeners to understand that OSA can actually come back, right? Particularly during puberty, maybe, even if a treatment like TNA seems successful initially. And persistent oral facial problems like that mouth breathing or poor tongue posture seem to be a big factor in treatment failure or recurrence. It all circles back.
That's a really critical point to emphasize. Yes, recurrence is a real possibility. Puberty is a vulnerable time due to hormonal changes and further growth spurts. And we saw findings, for example, that teenagers who had previous treatment but did not receive myofunctional therapy actually experienced a significant decrease in the width of their posterior airway space over time. It really illustrates the direct impact of that muscle tone and function on maintaining airway stability long term.
So given all of this complexity, the growth, the muscles, the potential for recurrence, what's the single most important takeaway message you hope our listeners get from today's deep dive, especially regarding the long-term outlook for treating pediatric OSA?
It means that the true goal, the only valid finish line, really, in treating pediatric sleep-disordered breathing, is the restoration of continuous nasal breathing, both during wakefulness and, crucially, during sleep. Because if that oral breathing pattern continues even after other interventions, it can lead to abnormal airway growth patterns resuming, setting the stage for the upper airway to collapse again later in life. So it's not just about stopping the snoring now. It's about setting that child up for a lifetime of healthy breathing and optimal facial development.
Wow. Our exploration today has definitely shown how pediatric OSA isn't simple. It's this really complex issue, deeply intertwined with how a child's face grows, and it clearly demands a multifaceted approach, looking beyond just the obvious symptoms. Early detection, early intervention seem absolutely paramount. And the surprising role of these oral facial mechanics, the muscles, the posture, that really can't be overstated.
Absolutely. So maybe a final thought to leave people with. Given this profound and maybe surprising link we've discussed between how we breathe and how our faces literally grow,
Hmm.
how might paying early attention to really simple habits like just keeping the lips together, maintaining that lip seal, ensuring proper tongue posture against the roof of the mouth,
Yeah.
how might that fundamentally profoundly change a child's health trajectory? Far beyond just stopping snoring, potentially influencing behavior, development, and maybe even mitigating some of those inherited craniofacial risks we talked about.
A really fascinating and quite empowering thought to end on. Thank you so much for sharing all this insight today, and thank you for joining us on this deep dive. We really hope it sparks your own learning journey.